you're in the top tier, Carol. A dedicated Colloquium supporter, an agricultural and health economist, associate professor in the Department of Global Health at UW. Her research is focused on the cost and cost effectiveness of introducing and scaling up public health interventions. And from my point of view, both selfish and thinking of the benefit of the field, the PI of the Global Health Cost Consortium, which has made a big effort with a multi-institution collaboration, including Sergio and myself and many others, to figure out what data we have and how we can do better at collecting and interpreting data about the costs, as you heard earlier, the cost curves of delivering interventions, particularly in HIV and TB, but setting the stage for other areas. So Carol, thank you very much for agreeing to moderate this panel.
Craig Cohen is a professor of obstetrics, gynecology, and reproductive health here at UCSF, but actually more importantly, he was at University of Washington up until 2003, and we've worked with many of the same people there. He is, today he's going to be sharing with you his experience as leading the Family AIDS Care and Education Services, the FACES project in Kenya. It's a PEPFAR-sponsored project, so he'll be giving a presentation. He has come very far today to be here, and so I'm not allowed to tell you how far he's come, but some of you will be able to guess at the end of his talk how far you think he came. He traveled today. Our second speaker is Katie Fox. She's a global health professional with over 7 years of experience in malaria, women's reproductive health, and HIV/AIDS, and she's the program coordinator on the economics and financing team at UCSF's Global Health Group's Malaria Elimination Initiative. And Katie's going to explore the cost of a malaria elimination program in South Africa, which I think is interesting given that most of us think about, I think we think South Africa is sort of better known for its high burden of disease in HIV. So over to you, Craig.
So I'm going to do my best to get to this talk. So essentially, I traveled 28 hours, and I got here at around noon, and 9 time zones later. But anyhow, I'm going to talk about something I know well. So I'm going to talk about HIV in Kenya and kind of the changing of the funding that is happening right now. It's been happening over the last few years and moving forward in regards to where the funding for the HIV care and treatment programs are coming from. And as a case, I'm going to talk about family AIDS care and education services. And for those of you who know it, it is FACES. So we're going to be talking about the funding trends and then specifically around some of the gaps and then what we've been trying to do as a program in order to compensate. So here we are. This is what OGAC, essentially the PEPFAR office in the U.S. government, they essentially have codified or typified countries into 3 different groups. So there is the, and I'm using Kenya as a country, and they actually use it as a country which has actually adapted very well to addressing the epidemic. And as you can see in the dark blue line, which is the number of new HIV infections, and the yellow line, which is the number of deaths in the population, you can see that over the last decade or more, there's been very significant declines in Kenya. Obviously, there's also been incredible investment, PEPFAR and the Global Fund and the country itself, that's helped to bring about this transformation. Now, as a country that's had some progress, but not as much, they have this middle ground, and Mozambique is a typical country that's used to demonstrate that. And for a country that's not doing so well as regard, there's where the epidemic is essentially stalled. Ghana obviously has much less of an epidemic, but there are also other countries as well that fit in this category. And essentially what PEPFAR is planning to do and already doing is essentially taking money from the very high-performing countries, like Kenya, and giving it to the countries that are not performing very well. I'm not sure what's happening in the countries in the middle. So the question is, which we can talk about later, is does that make sense or not? And if it does, how would you qualify the way that makes sense? So this is the funding in Kenya over time. If we were to take a look at the funding by years, by the COP years, which is the country operational plan, this is something that OGAC creates with the in-country parts of the U.S. government, so USAID and CDC, Department of Defense, and they come up with a COP every year for every country. And you can see that we had over $500 million in Kenya, about $550 million in COP 17, but a 22% decline for the current COP that we're in. And Kenya has not finalized the COP planning for this next year for COP 1920, but we're expecting at least another 20 to 25% decline from the current year. Now, when we take a look at the current number of patients on antiretroviral therapy, these numbers continue to increase. Kenya, in many different counties, and including the county where we work, we essentially have attained the 90-90-90 threshold, the UNAIDS 90-90 threshold, which means 90% of the people in that community or the county have been identified as living with HIV. Of those, 90% are linked to care and receiving antiretroviral therapy. And then of those, at least 90% are virally suppressed. We can also see over time that the cost per patient being treated has declined. Again, the money's gone down. The number of patients is going up. So we can see we peaked about 470. Well, actually, the peak was probably much earlier. But as the programs became more efficient, $476 per patient in COP 16. And in COP 18, we're at $321. These are all inclusive of service, the drugs, and certain aspect, also the indirect costs as well. So the country and the implementing partners, which FACES is one of the implementing partners, we've had to become more efficient in our provision of care and support to these communities. We are now supporting the Ministry of Health in Kisumu County. We support them in about 70 different facilities. All these facilities aren't equal. About 80% of the patients actually are going to about 8 of the facilities. This links in with Margaret's talk, the one preceded. We now provide support to about 47,000 people on ART. In addition, we do about 40,000 voluntary medical male circumcisions. We test, I'm not sure this last year, but probably around 700,000 people for HIV. We do any other things in the community and at the healthcare facility. We provide the care and treatment, that's a big focus, but also prevention of mother-to-child transmission, HIV testing and counseling, circumcision services. And we also integrate this with the reproductive health. I am an OBGYN, and my partner, Elizabeth Bakusi, who is at Kenya Medical Research Institute, essentially is the co-PI of FACES, so we're both OBGYNs, so we have a big reproductive health focus. Now, when we take a look at what I'm dealing with as the PI of the program and working with our team, both here at UCSF, but also mainly in Kenya, in COP 17, we had $11.7 million for our program. This year, we have $9.2 million, and we're projecting $7.2 million for COP 19, which will represent a 38% decrease over 2 years. We have not been given our numbers yet, so these are estimates. And as I showed earlier, and for our program as well, the number of people that we're taking care of has increased. This provides lots of challenges, some sleepless nights, because our real goal is to ensure high quality provision of HIV care treatment and prevention services to the people of Kisumu County. Now, when we take a look at some of the impacts of our program, some of our measures, again, we have various cascades. I'm limited by the time of my talk, so I'm not giving you the whole cascade. But I decided to focus on viral suppression, which is a relatively sensitive indicator of the success of a program. And as you can see, for adults, those are 25 and greater, and young adults, 2024, we are reaching or surpassing the threshold, the 90% viral suppression threshold. However, like many other programs, not just in Kenya, but in other low and middle income countries, we have not attained that target yet for adolescents or for children. We have been making steady headway, but again, addressing these gaps is really a big focus of our program. The technical expertise of our program, our team in Kenya, really helps to work hand in hand with the Ministry of Health. Now, this is, just to let you know, In the county where you work, it's one of the four very high burden counties in Kenya. The prevalence is anywhere for reproductive age women is 18 to 20%. It's about 14 to 15% for reproductive age men. And at the 70 facilities where we support HIV care and treatment, 8 of 10 of the healthcare workers is supported by FACES. These are all the healthcare workers in the facility, whether they're doing MCH, whether they're doing outpatient department. So this is a huge burden for our program. And as you can imagine, with the declining resources that are coming, that we've already had to absorb and that are coming, this is going to be a huge challenge, not just for taking care of the people living with HIV in Kisumu County, but also for the women coming for antenatal visits, for the people going to the outpatient department, for taking care of people with non-communicable diseases, et cetera. In fact, only 31 facilities have any MOH permanent staff employed. So we have sharp decreases in funding. We've created lots of sustained epidemics, gains in regards to the epidemic. I mentioned around the 90 ascertainment, and in some cases we're surpassing that as well. So in regards to challenges, we have a real reliance on donor funding in this very high burden county. And again, all counties are not equal, and I actually had a conversation with the person in charge of health for Kisumu County, Dickinson Nyanga. We had a very productive information. The country right now, I don't know where Margaret is. Is Margaret still here? Did she leave? Oh, she left. That's too bad. It would have been interesting. Anyway, so the country right now, essentially, because it's a disseminated program out to the 47 counties, gives a per capita allotment to each county. So it's not based on the burden of disease in these various counties. So Kisumu County, if they have 1 million people, which is about the population, gets the same amount of money as a county that has a low burden of HIV and maybe perhaps a higher burden of NCDs. So they both get an equal allotment. It's not based on the burden of disease. And that has left a huge deficit in a place like Kisumu County and other neighboring counties around Lake Victoria. The MOH really has not invested properly and I would say that perhaps the bilateral donors such as PEPFAR have actually contributed to this, because if you're now with the county system, which has been in existence for about 8 years, if you have a budget, whatever your budget is for your county, and health is being taken care of by the donors, then you're going to invest in other aspects of your infrastructure and economy. And we still have been working a lot to help build up the management skills of the county health management team as well. I was just talking about Kenya, Margaret, but you were just out of the room. I was just mentioning, it's okay, just mentioning that to my understanding, the counties are given a per capita allotment regardless of the burden of disease in that county. And so I'm advocating for more resources for Kisumu County where we work. Well, and the other high burden counties too. And you saw 8 of 10 healthcare workers in our county are funded through FACES. So that's not sustainable with the declining PEPFAR funds. And I'm worried about this, and I'm not the only one who's worried about this. So there needs to be a greater transition to the MOH ownership of this program, and specifically of MOH taking on hiring the healthcare workers that are required at these various facilities. In fact, Kisumu County is one of the 4 test counties in the country for universal health coverage. What this exactly means, to be honest, I'm not clear. Maybe Margaret has greater insights. I'd be interested to know. But there is this money that I know that's in the budget for about $840,000, which translates to about 137 staff. Now, Dickens Onyango, the person who's in charge of health, thought he controlled that money, but he learned just about a month ago it's actually the Ministry of Finance in the county that controls this money. So we are yet to have that proper conversation to have them allocate this money to decreasing our burden so that they're more permanent and pensionable staff within the healthcare system, or even if they're not permanent as well. We need to maintain the technical team. Without the technical team, which is comprised of a few people, just a handful of people at UCSF, some of the people in the crowd here, as well as our esteemed leaders in Kenya from Kemri, we're not going to be able to sustain and be able to be the innovators that we've been able to do in Kenya. So we need to build sustainable teams within the counties in partnership with the county health management team, also working with the other donors that work there. We need to continue to maximize efficiencies, but to be honest, I don't know how much more juice we can squeeze from what we have. And I'm really worried with the next decline that we are going to see declines in the quality. And our program has been at the paramount of not just quantity, but really quality. We need to have greater cost sharing, and we're trying to do also have research money coming in, which is really not other way to sustain the program. And then we need to have rigorous financial and target attainment review, including the county and the counties in the country need to become empowered and learn how to actually develop health management budgets based on their actual needs within their county for their people. So I just want to thank you. This is part of the FACES team, and say El Rakamano, which is Duluo, for thank you as well. So thanks. And these are some of the people that helped put together the presentation. Michelle, who's here, and Jane Kulzer. Purba, where are you? Oh, in the back. Okay. Thank you.
Okay, I am acutely aware that I'm the last presenter in a very fully packed day. Hopefully this won't be too unpleasant. Today I will be presenting on an investment case in South Africa that estimated the costs of eliminating malaria and generated economic evidence that highlights the benefits of doing so. So this investment case emphasizes the importance of your intervention portfolio in a resource-strapped setting. So we're going to discuss how the South African malaria program can build the most effective package of interventions to optimize its chances for elimination. So just a little bit of context. Momentum towards elimination and eradication has been growing for decades. Today, more than half of the world's countries are malaria-free. Since 2000, there's been a global surge of progress. This has been facilitated by a rollout of new technology and then pretty substantial growth in financial and political commitment. So we see annual domestic and international spending on malaria has increased from roughly 1.5 billion in 2000 to 4.3 billion in 2016. That's great. We're really inspired by these achievements, but there has been a recent stagnation in progress and a plateau in financing. Elliot talked about this morning, that the golden era of rapid increases in global health funding is over. So we have to do more with less, which means we need to be smarter about our investments, particularly when dealing with the unique challenges of lower burden countries like South Africa. So a little bit about malaria in South Africa. They've been doing a really good job since 2010. They saw steady progress, experienced a very severe outbreak in 2016, as you'll see by these really impressive gains in cases. Over the past 5 years, malaria in 2 of the 3 endemic provinces have been acquired by other countries. So importation accounts for 82% in Mpumalanga, which is in the middle, and then 72% in KwaZulu-Natal. So pretty high significance for South Africa's elimination trajectory, and that's going to come into play a little bit later in this presentation. This horribly formatted table shows the public sector case management costs before and after the outbreak. The biggest takeaway here is that costs increased by 1,100% in Limpopo, 570% in Mpumalanga, and then 73% in KwaZulu-Natal between 2016 and 2017. This put a huge strain on the healthcare system and the malaria program, who were not necessarily expecting or prepared to shell out this kind of money. South Africa faces a couple of other different challenges. Unlike the rest of sub-Saharan Africa, South Africa's malaria response is almost entirely domestically funded. So to eliminate, they have to increase and sustain their domestic investments. Challenges remain within the endemic provinces. They lack sufficient budgets to implement core interventions like IRS and surveillance. Their budgets are also based on historical trends that have had low or zero growth. They're just not reflective of their actual need, which makes it hard to plan. As Carol pointed out earlier, malaria in South Africa has to compete with HIV and TB. South Africa still has the largest number of people living with HIV in the world, and together HIV and TB are nearly 80% domestically funded in South Africa, so that often pushes malaria down the priority list. And then finally, cross-border migration is one of the most significant impediments to elimination for South Africa. The figure here on the right shows the sources of importation for both South Africa and Eswatini, but your takeaway is that in South Africa, roughly 92% of imported cases are from Mozambique, specifically southern Mozambique. So that brings us to the investment case. The objective of this project was to help support the malaria program so that they can be adequately and sustainably financed for elimination. We want to help them ensure that they have sources of finance that are responsive to their changing needs and that they can allocate and utilize resources effectively. Ultimately, we want this malaria program to have the capacity and political will to mobilize and manage resources. So we leveraged several different approaches, but basically estimated the current and future cost of elimination, the economic returns of eliminating, and then we explored the feasible and sustainable financing options. Ultimately, that begs the question, how do we define what are feasible, affordable, and optimal intervention components for a malaria program? In South Africa, we used mathematical modeling. So a bespoke epidemiological economic transmission model was developed by our partners in the Modeling and Simulation Hub in Africa. And this simulated malaria transmission to predict the impact and determine the cost of current and future interventions. This methodology has the potential to both improve the predictions of the course of transmission, but also support the development of novel approaches to the management of malaria. Bottom line, we employed modeling to help decision makers choose a course of action. And there is certainly an ongoing and healthy debate around the limitations of using a model. I think the ones that we talk about the most in our group is how the challenge of supporting a decision with imperfect data or information. But we believe that modeling in this context allowed us to quantify and assemble pretty diverse factors relevant to program decisions in a way that would be otherwise impossible. So a couple of model characteristics. I'm not a modeler, so please don't ask me questions. We modeled at the subnational level to account for the heterogeneity in transmission and then also program activities across the provinces. So interventions and costs were modeled separately for each of the provinces. And then we had a cost estimation model that was aligned with the outputs of this transmission model to estimate the total costs associated with implementing specific scenarios. Program costs included the costs of treating uncomplicated and severe malaria, vector control, surveillance, et cetera. So for today, I'll be presenting on 4 buckets of scenarios. We did model more, but so we've reversed, continue, accelerate, and innovate. The key transmission features and drivers of transmission in the model were infection classes dependent on the level of severity, the development and loss of immunity against clinical infection, superinfection, subnational receptivity, and then importation of infection. So I'll just run through these. Continue, it reflects business as usual. That's pretty straightforward. And I'll have some more details on the next slide. Accelerate scenario includes enhancing the existing set of interventions and then scaling up border units in strategic locations across all provinces. And border units in South Africa are essentially surveillance units that are used to detect and treat local, but specifically mobile and migrant populations. Accelerate is also going to see an increase in IRS and reactive case detection. And then the innovate scenario, which we call the source reduction scenario, reflects the scale up of accelerate and then simulates an aggressive approach to reducing imported cases by implementing activities in southern Mozambique. So this scenario also includes strategic distribution of bed nets in Maputo and IRS in Gaza and in Hambane. Those are all within southern Mozambique. So I think it's important to note here that neighboring countries in the region were included in the model depending on their contribution towards malaria in South Africa, Mozambique, southern Mozambique, being the biggest contributor. So this approach, which is attempting to secure funding to implement activities in a different country, is largely new and the first step in strengthening regional efforts towards elimination in South Africa. And I skipped the reverse scenario, but that it's just a counterfactual scenario that's employed to illustrate the pretty severe consequences of halting interventions or reducing IRS by 50%, for example. So these are just a couple more notes on these scenarios. So business as usual, this is just what South Africa is doing today. They're doing passive testing and treating. They have reactive case detection at limited levels in Mpumalanga and KwaZulu-Natal. They are not doing reactive case detection in Limpopo at all. They have case investigation at limited levels, and then limited IRS coverage. And then I think in the interest of time, I'm just going to skip forward. So the results, as shown by the green line here, the source reduction scenario is going to get South Africa to elimination the fastest in 2026, and that's what the little yellow star indicates. So under this scenario, KZN will be the first to eliminate in 2021, followed by Mpumalanga in 2025, and then finally Limpopo in 2026. And then the source reduction scenario, so this is the top line, and this is in South African rand, but it will cost roughly 5.8 billion rand over 11 years. This is about 375 million US dollars. This scenario will avert nearly 50,000 cases, 900 deaths, and generate benefits of 1.97 billion rand. And again, that's almost $120 million. Benefits here, we kind of lumped into three broad dimensions, and these are really just the cost averted to the health system, so think diagnosis and treatment, the cost averted to the households, which is out-of-pocket expenditures, and then cost averted to society. So that's the productivity losses to patients and their caregivers. So when we compare this to the other scenarios, we see that while this intervention is certainly the highest cost, it elicits the greatest return, both economically and then epidemiologically. So what's next? What does this mean? We generated a lot of data. These provinces have some serious milestones for being set, and then we see that elimination in South Africa is not only feasible, but it is worthwhile. So the investment case findings demonstrate here that there is a need for a multifaceted approach to elimination. National elimination is not going to be achieved without increasing regional efforts, nor will it be adequately financed in doing so. So I'm excited to report that the investment case was successful in mobilizing 22 million US dollars from the South African government over the next 3 years under a new conditional grant. This is a 41% increase in domestic financing from 2018 to 2019, which is a huge win. Let's see. And then an additional $4 million pledge from the South African government to create a co-financing mechanism with Mozambique has been brokered. So the initial focus on this co-financing mechanism will be funding the implementation of IRS operational research and then monitoring and evaluation of interventions in southern Mozambique. This mechanism aims to facilitate a more sustainable, country-owned approach to elimination in southern Mozambique and then enhance the existing partnerships with Mozambique, South Africa, and global stakeholders. I think I'll just end with, this morning, Dr. Gooseby mentioned that the ability for one country to engage with another country regarding program implementation is really imperative to the success of achieving a global health goal. And so we hope this investment case really just continues to facilitate dialogue to deliver appropriate services to eliminate malaria in South Africa, in Mozambique, and then in the region. So I'll stop there. And then I just want to give a shout out and big thanks to my colleague, Aparna Kolipara, who's here today, who was integral to the success of this project. Thank you.
I sort of wanted to be provocative, but I'm reluctant to be provocative, but I might be slightly provocative. And I want to, I wish Elliot were here a little bit, because what I'd like to do, and I'm going to just have a question maybe for each of you, and then turn over to the audience. For Katie, we kind of, Elliot asked us about, he put up these different things to think about, efficiency, what's the ethics of it, equity. And I guess I'd like to hear sometimes I think about this, like why elimination? Why are we putting money to malaria elimination? Why that goal? Is it ethical? Is it efficient? What's the rationale? You know, what are some other arguments to your investment case? So thinking about that, because the topic of this session, as you all know, was ambitious programs with constrained resources. And the reality is we always are in an environment of constrained resources. Right. So that's my question for you. And then I guess, was FACES more than just an HIV program, or was it really around HIV, or was it quality care for a bunch of things? I couldn't tell if it was HIV focused but I have a question on how you're going to answer that.
So FACES is an HIV care and treatment program funded by PEPFAR.
Yeah.
But we've used it as a platform for a lot of clinical and
Okay.
operational research and strengthening the healthcare system in general.
So my question for you, and it's just a sort of a thought question, and I think what we really get very involved and passionate about the areas where we work, malaria, HIV, the regions we work, the governments we work. And so you mentioned this, how PEPFAR being there, by being donor-driven, the government has stepped away. Thinking back for the time that you've been in Kenya, and thinking about really what we heard today from Margaret on the need to sort of strengthen systems overall. And you've given some ideas about how to go forward. Would you have done something maybe different if you had been thinking about that resources wouldn't be flushed forever? So those are kind of two hard, not very nice questions for the end of the day. So Katie, go ahead and answer, and then Craig, and then we'll...
Thanks, Carol. That's a really important and really big question, and I'll encourage everyone to read our Lancet Commission on malaria eradication, which is coming out soon. But I mean, what I put up there, the ROI for the source reduction scenario is almost 7.5 to 1. So for every rand invested, you're going to get 7.5 rand back. I think that estimates a fraction of the quantifiable benefits. There are additional benefits that are just not monetized. I mean, we're thinking about things like improvement in education and cognitive development, in tourism, foreign direct investment. So yeah, is it ethical to advocate for malaria in a place where the HIV burden is so high? You know, I don't have the answer to that question, but I know that it opens up space for more lives to be saved. It reduces morbidity and mortality. It generates economic benefits. It increases productivity and wages for workers. But yeah, it certainly is a question that we are thinking about. I can speak for our group at MEI that, you know, we think eradication is possible and should be pursued.
I mean, you kind of asked me an impossible question because I'm not the funder. It's really an issue between governments. It's really an issue between the U.S. government and the Kenyan government in this context around PEPFAR. And the U.S. government, of course, putting pressure for a greater amount of local investment by the Kenyan government itself. And at the same time, you've also had this, with the new constitution, you've had devolvement of the government to the county level. And there's still a lot of, you know, it's a relatively young democracy. And there's still a lot of, since the constitutional change, there's a lot of trying to figure out who has the power. And health is one of those ministries that has been more centralized as far as decision-making and financing than as far as other ministries. So it's really a difficult situation, and certainly I've taken part in discussions with our funder, which is the CDC in Kenya, to make it known what's happening. They're aware of the issues, and yet, you know, then of course, the way they get pressure put on them by PEPFAR, by the PEPFAR office as well, and they get pressure put on them by Congress. And so it's this big political issue, and now we're gonna, yeah, when the money was increasing all the time, it wasn't a big issue. But, well, it was an issue, but now as the money is declining, this is where we're gonna have a real challenge maintaining that high quality of services to the people of Kisumu County and beyond for the other counties in the country too.
Thanks. Any questions? Yeah.
This is about malaria elimination or malaria, more than elimination in South Africa. You have already documented to us that the huge proportion of cases that are coming from Mozambique. Mm-hmm. And the part of the elimination campaign would be to provide some efforts along the border.
Okay.
And all of this depends upon the validity, the fidelity, the accuracy of this model to predict that, yes, you're going to totally get rid of malaria. And I'm curious if this model has been applied elsewhere and demonstrated elsewhere that in many other countries in sub-Saharan Africa where they have malaria, that yes, malaria elimination, in fact, follows exactly what their model predicts. And under those circumstances, I'd say go forward. But I have a lot of hesitancy about whether they are actually going to totally get rid of malaria with the problems that they have with importation.
Sure. Well, I mean, I think that's the biggest question mark about a model is that it's imperfect. It's hypothetical. So this model that we employed in South Africa, it's part of a suite of models that have been applied in Asia Pacific. So we did a regional model for Asia Pacific and then a sub-regional model in the GMS. So it looks a little bit different than this. It includes Vivax, of course. But I think ultimately the takeaway is that this investment case, it produces these numbers, but what matters the most is the people making the decisions to then allocate money based on these findings. So it's really an advocacy tool, right? Basically, we were able to facilitate conversation with the government of Mozambique, which is not the easiest thing to do, to say, listen, South Africa is willing to give you all of this cash if you can get these activities implemented. What's important is that future financing for activities and interventions in southern Mozambique will be contingent on performance against KPIs. So it will be performance-based in the future, which is good to keep, to ensure accountability. But again, yeah, modeling is always a question mark. And I'm happy to put you in touch with our modeler if you have any more questions around it.
It sounds like a great success that they chose to invest money based on the results. Thinking about the trade-offs then, do you have a sense of where that money, what wasn't funded because of that money, was that considered in the return on investment case as opportunity costs of something not funded? I'm thinking of perhaps it was an HIV study, and just using Craig's experience in Kenya as an example, he's reducing funding. So there's always these trade-offs going on. So do you have a sense of how that's incorporated? And then kind of all of today is making me think about what the role of, as countries are starting to build holistically, or starting to pursue holistically universal health coverage, is there a role more broadly for economics to health technology assessment groups to develop alongside that and start having broader discussions around optimization at the same time at the local level?
So yeah, I think I can answer your first question. Because of the domestic financing mobilized, the $22 million, this was now put into a conditional grant, which now is sitting with HIV and TB. In South Africa, HIV and TB had their own conditional grant, in which the burden is higher, the need is more. There are still gaps in malaria. There's huge resource gaps, resource capacity gaps. There's not enough spray men. There's not enough. The management capacity is lacking. Leadership is lacking. And previously, the malaria funds were not protected. So oftentimes we're seeing where HIV and TB can kind of go and grab that money. So this is a step in the right direction to earmark for malaria. Of course, there's an opportunity cost, and if we want to, we can go back and talk about ethics, but we want to reach elimination locally and then across the border. So we think it's worth it, and it is affordable.
Over to you. Thank you very much. Thanks to our students.
Katie's answer reminded me of the famous adage, all models are wrong, some are useful. And I stand by that. Thank you, everyone.